everyone. Good morning and welcome to Vivian Health series on the horizon in healthcare. Today, I'm really excited to talk to you about average daily census and staffing and hours per patient day. And I've asked one of my colleagues who's an expert in nurse staffing to come and talk to us today because, as you all know, it is just a really competitive job market right now. Nurses are very active in the job market, looking for jobs. Every employer is recruiting for nurses. And so certainly one question that will come up in an interview is how does your organization do staffing and scheduling? And how many patients will I have? And what kind of schedule will I work? So those are always really important questions that'll come up in an interview. And so today I've invited Dr. Therese Fitzpatrick to join us and talk about her expertise in workforce optimization. And so I've known Therese for many years. She's an expert in this area. And she's the senior vice president at Kaufman Hall and a member of the firm's strategic and financial planning division. And in this division, she works with hospitals and health systems across the country on performance improvement. So she consults and helps them understand how to make their workflows more efficient, how to improve operational performance, and how to develop really effective strategies around staffing and recruitment, and especially budgeting and how to collaborate with the folks in the finance department. So today we want to talk about workforce optimization, and especially, again, in this really tight labor market, what are some of the things that a candidate is potentially going to ask? And we'll have some ideas for you at the end. So, Therese, I think I'm so glad you're here. Thanks. It's wonderful to see you.
Good to
so
see
early
you.
in the morning. And I want to start with one of the things that you and I have had many conversations about. Why is it that we continue as a nursing leadership profession and finance teams to use average daily census at midnight and hours per patient day for nurse staffing and budgeting when you've got many stories about that's an antiquated system, and yet it still is there. And so can you talk a little bit about what that's about?
Sure. And thank you again for inviting me this morning. Particularly the two metrics that you mentioned actually date back to using average daily census marked at midnight is actually something that dates back to the 1960s when we invented Medicare. And organizations needed to mark a point on the clock where they were able to drop bills and sort of count the day, if you will. Back in the day when patient days were a critical piece of how we billed for care. Unfortunately, that metric has not, it's still, as you mentioned, still being utilized. And while it works really well for billing, it does not necessarily serve us well in terms of understanding what's going on with patient activity throughout the course of the day. Hours per patient day is a metric that dates back to the 1980s, actually. And it does not necessarily reflect the nuance and the complexity required in caring for various types of patients. So it is essentially a metric that says that a medical surgical patient on this particular unit on average requires 8 hours of care or 9 hours of care every day. And it really doesn't help us understand what is that care. And it's not just physical tasks, as we know as nurses. There is much more that we do in terms of planning and education and managing that episode of care than necessarily are reflected in those numbers. With using averages, we run into a greater issue that we like to call the flaw of averages. So when we base a budget based on an average daily census marked at midnight, and the only sort of qualifier that we use in terms of understanding the care requirements, we build a budget that is pretty static, even though the activity and patient acuity move significantly around that. It is in that movement, that variation around the budget and around the average, that I believe creates much of the chaos that we see with staffing. So what happens when our numbers drop below that average? We're pushing away from the unit. So that means we're floating staff. It is not unusual in some organizations to see our colleagues being sent home and sort of put on call, and all of that leads to tremendous disruption in activity on the unit, and certainly disengaged staff. When on the other side of that average, demand on the unit goes up, acuity goes up, now we're searching for staff. And that, as we know, takes the form of blast emails. You're receiving multiple calls 24 hours a day to come in and contribute to staffing on that particular unit. So averages have not served us well. And as our world becomes more complicated, they serve us less well.
Right. Well, and we've all talked about that churn that happens on the unit. You may only have a 25-bed unit, but you could have 30 patients or 35 patients go through that unit, and you'll never know that if you only count them at midnight. And so that's really, many of us talk about the churn as one of the challenges that we face.
That's right.
So when you come in and do workforce optimization, it's I always like to think of it as the really fancy math. It's a new technique that we really have only had the computer power to be able to do, as well as the data. So talk a little bit about why workforce optimization, that methodology, is a more powerful way to do nurse staffing, which at the end of the day makes the staff a little bit feel better about not having such variability in their schedule.
That's a great question. So optimization science is used in other logistics-oriented industries. So think about the math that United Airlines uses to manage really complex logistics problems. Thousands of planes in the air at any point in time across multiple time zones. UPS, in terms of delivering packages, has to solve very complex logistics problems every day. So that math is sort of situated in linear programming, stochastic modeling, and as you call it, the fancy math, if you will. So what we have done in terms of nursing workforce optimization is essentially take that mathematics, those sort of mathematical techniques, and applied them to solving our really complex scheduling problems that exist within our clinical workforce. So with linear programming, it's really sort of an interesting way to solve a problem, in that you start with the end in mind and sort of work backwards. So you first need to identify what is the business problem that you are attempting to solve. And we have identified three outcomes. So it's how to achieve the best coverage on a nursing unit, defined by that unit, by leaders on that unit. So that is looking to our evidence-based literature, looking to our professional organizations for staffing recommendations. So the Emergency Nursing Association, AORN for perioperative areas, and so forth. So it's business outcome number one is best coverage. The second business outcome is at the lowest cost. And then we look at staff engagement with the process, but obviously that is a trailing indicator, but nonetheless a critically important one. So in linear programming, just to do sort of a quick primer, back to our graduate school math days, what you do is identify all of the constraints and variables that exist in these really complex systems that need to be accounted for. So we begin with, and I'll ask you to sort of envision a great big Rubik's Cube, if you will. And the first sort of layer of filling in the little boxes on the Rubik's Cube are understanding the demand. And we would suggest and have done some regression analyses to demonstrate that if you look at 3 years of hourly demand on a unit, you have about 95% reliability in being able to predict what that next year is going to look like. So we have, rather than using averages that ADC marked at midnight, we have very, very discrete demand data that rests in our electronic medical records. So we're able to extract what's going on every Tuesday on 3 North at 1 o'clock in the afternoon. And we do that by hour of the day, and that sort of fills in the first layer of boxes on our Rubik's Cube. The second, and critically important, but often overlooked, is the quantification of our various work rules. So as nursing leaders, we know intuitively in an organization where our colleagues work every other versus every third weekend, for example, you need a very different configuration of budget in order to make sure that we have staff available. So we have identified about 20 of those work rules that need to be quantified as we develop our optimization models. So it's things like, and we always encourage a look at the literature to make sure that we are staying on top of leading practice as it relates to safety, patient safety, and our colleague safety as well. So things like how many consecutive 12-hour shifts should a nurse safely be working, both for his or herself and for patients? Things like every other weekend and so forth. All of those work rules can be mathematically quantified. So that becomes the second layer on our Rubik's Cube. The third layer then becomes, based on the expert assessment of leaders on the unit, what should that staffing model look like? So going back to, again, our professional organizations, NDNQI provides some great benchmark data for us to consult as well in terms of what should that typical, and if you've got acuity data, acuity adjusted typical assignments look like. So now that we've created this big Rubik's Cube, we put it on top of what's called a math solver. It essentially spins that cube through hundreds of thousands of possible ways to solve the problem. How do we get best coverage at the lowest cost? The map, however, does point to the best solution out of hundreds of thousands of possible solutions. What is the best one to get us that best coverage? So from the output of that model, we're able to very precisely configure budgets. So not just in the old way of thinking 50 FTEs for 3 North, but this is able to point us to exactly how many 0.9s, 0.6s, so on and so forth. The other sort of really interesting piece of this is because linear programming allows us to look three-dimensionally, we're able to take those Rubik's Cubes across an entire clinical division, run the model, and understand how demand behaves across, for example, all med-surg units, and very precisely configure what the float pool looks like. So this gives us, back to your initial observation, it gives us much more precise understanding of demand so that we can better staff to demand, stopping that chaos of either pushing staff away or pulling them in. It also allows us to develop very predictable schedules so that those of our colleagues who would love to know what their schedule is going to look like for the next year to manage that work-life balance, they're able to do that.
Well, and the one thing that I want to just go back, I wrote a note while you were speaking, that I've seen those heat maps that come out of the data. And so for those of you who are familiar with heat maps, they show if hot, and it's red or yellow or green. And when you're looking at the patient demand every hour, you begin to see the churn. And then on the heat map, it comes out really red. And so that really red might mean, oh, we need a couple of 4-hour nurses to cover this time versus, and so I know you're going to talk more about that at the end, but I think it's really, I don't know of any other methodology that understands the demand for patient care on a unit at the hourly level. There's you can't capture that any other way, but then you this big fancy math. And that's where to me, that was always very dissatisfying. You may know that you're going to have 4 patients if the ratio is 4-1, but that might mean 6 people, and it's like it's a little unsettling. You don't really know what you're up against when you get to work that day.
That's right.
Very, I think that's really stressful for nurses. I get that.
Yeah.
So if a hospital or a health system decides, okay, we would like to take on this kind of work. We would like to, engage an organization, come in and help us do workforce optimization. Given what you've described and how complicated the math is, I would imagine it's a pretty big team that comes together with different departments. And so talk a little bit about how these projects sort of happen and how they unfold, if you will.
So, and as you might suspect, given the complexity, there really is, there truly is something to this notion that there is an art and a science as it relates to staffing, and not just staffing, but how we do the budget as well. So I work in really close partnership with engineers and mathematicians around this. So as a nurse leader, I'm able to bring in the qualitative piece, but that really needs to mesh up with the math. And I look to industrial engineering colleagues and statisticians to help with that. So that's sort of what my team might look like. I think it's really important to engage because staffing and scheduling touches all layers of the organization within our complex nursing organizations, that we have a representative group from all different units. As we know, demand behaves very differently in a critical care unit than it does in ED, to make sure that all of those voices are represented. And we often will work really closely with an organization shared governance group. So sometimes in some organizations, those look like staffing committees, and in others with a different sort of configuration of their shared governance group. We think that's really important. We also highly recommend, that we do a survey of our staff colleagues before we begin all of this design work, to really understand from the perspective of the individuals who are impacted so closely by schedules, that we understand what's working well, what isn't working well, and we consider their voice very, very strongly in this work. We also recommend that we have our partners at the table whose voice and participation is really important for us, even from an educational perspective, that we have finance and human resources, for example, decision support at the table as we design this work as well.
Yeah, and I've been involved in some of those projects with you, and it is it's such a dramatic change to the entire process that it requires really a lot of education across so many different departments, because you're literally changing the approach all along the way. And so it's really important that everybody, so it's a big team, but then there's sub teams, and then And then, and I know I've seen you where the original models come out, the initial models, and then you come back and talk to the staff and say, okay, nurses,
Yeah. Yeah.
did we get this right? Do we have to tweak
That's
this a
right.
little? Is this what your day is really like? So there's a lot of opportunity for the staff to have input. And I think that just goes a long way. And from what I've seen too, they're thrilled when they have a schedule that can be
Yeah.
longer than the typical schedule. And then
Yeah.
let's talk a little bit about the float pool and
Mhm.
this whole process optimizes the work and the schedule for the staff nurse. And I want to,
Mhm.
but talk about how you've got the staff core and then
Mhm.
float pool and how those two groups have to be right sized as well.
Mhm.
Manage that,
That's right.
right?
Um, that's a great question, and when you think about it, it's in many of our larger health systems. There, we're talking about how do we optimize together our core staff on the unit, perhaps a hospital-based float pool, and even an enterprise-wide float pool that we're seeing as staffing alternatives to in some of our larger systems. I've heard this described by a nurse leader that I've worked with as it's not your mother's float pool. So this is not the float pool of old, where there was a sort of group of staff that waited for the call in and they were deployed at the last minute to cover call ins. While that is a portion of the float pool, we would suggest that, and oftentimes part of our staffing issues are because we have not precisely understood what the backfill needs are. So how many organizations sort of have historically approached that is that they have used a single sort of backfill percentage across all departments across the entire organization. And what I mean by backfill is how do we cover for leaves of absence, vacation time, those sorts of things. So in understanding and part of understanding with optimization, the precision here, that needs to be configured on an individual unit basis. So if we've got a unit with many late careerists versus a unit with younger entry sort of career folks, their use of vacation time looks very different, leave time looks very different. So there needs to be precision at understanding that. And that needs to drive that very precise configuration of the float pool, who becomes sort of a critical part proactively in filling those holes in the schedule with the goal of posting schedules with as few holes as possible. So that our float pool colleagues are a critical piece of that.
So, Therese, when you come to the end of a project such as this, what do you hear? What do you and your team members hear from staff nurses? You mentioned that you start projects with a survey to understand those issues that the staff are feeling. So when you end the project, what do you hear from staff about, the process and how it's impacted them?
It is pretty typical to see a pretty big bump in staff engagement around staffing and scheduling as a result of this. And I would say it sort of boils down to a couple of things: predictability and that notion that you addressed earlier. When I am driving to work every day, I want to know that there is sufficient staff available to take care of patients on the unit. So any part of the process that will help us make sure that schedules are completed when they're posted helps to bring that level of assurance to the staff. And then as it relates to their own very predictable schedule, it allows me to very proactively sort of manage my personal life, my personal schedule around that as well. And there is always the observation that there are fewer phone calls being made to me throughout the course of a day in order to come into work. I don't feel guilty when I say no. So there is a level of increased satisfaction around that as well.
Yeah. And I think that, I've been to a number of hospitals as you have, and the amount of text messages
Yeah.
that fly back and forth between
Yes.
the manager, the charge nurse, the
Yes.
staffing office, the staff looking for stuff. I mean,
Yeah.
it's mind-boggling, and
Yeah.
it's just horribly inefficient and
Yeah.
wastes so much time. So
That's right.
it's nice to have more predictability around
Yes.
what's happening. And it won't be a surprise, because if you've looked at 3 years of data, of patient data,
That's right.
you know what's coming. That's why I think you can't just look at 1 year of data. You really
Yeah.
need to go back and understand.
That's right.
Because you always forget, everything will be terrible if you just think of last year.
Right. Right.
To balance that out a little.
That's right.
So if there was one piece of advice or recommendation you would give to the HR team around recruitment of nurses, is there some kind of pearl of wisdom or advice, or even for a nurse executive, because that's who will be listening to us today? Like, how can some of this translate to their environment?
So two or three pieces of advice. So for our nurse leader colleagues, our executive colleagues, it is understanding, and now is the time for us, given our computational abilities, given the fact that our medical records and our finance systems hold a treasure trove of very, very specific data, now is the time for us to be able to do much more nuanced staffing and scheduling based on the unique characteristics of our units. We don't need to rely on averages anymore. We have those data available to us. So that would be my advice for our executive colleagues. For human resources, I would definitely recommend staffing and scheduling is critically important to those of us. Irrespective of sort of what role we have, the ability to have some predictability and not have a lot of chaos around staffing and scheduling is really important. And when you do that well within the organization, you need to lead with that as you're recruiting staff, because that could become your differentiator. As it relates to our staff nurse colleagues, these are important questions to ask during an interview. And really sort of dig in. How does it happen? How long are schedules? What are some of those work rule requirements? So that you're not surprised when you come in. And I will tell you, the more that you ask these questions during an interview, that will help the organization begin to understand the importance of those employment characteristics, and that will help us move change as well.
Well, I think that's such an excellent point, because and I remember a story you tell, when you're at your desk every day, Monday through Friday, 8 to 5 or what have you, your schedule's not disruptive, because it's every day. That's not how a staff nurse lives their life.
Exactly right.
And so you don't really appreciate that unless it's top of mind while recruiting a candidate, that's a really hard thing to live with. And you as HR may not have that much variability.
Right.
But boy, other folks have to manage their lives around that. So
that's right.
Such a great point. So thanks, Therese. I mean, this
pleasure.
is wonderful. And
my pleasure.
I know folks who are listening will be very intrigued, and maybe a little bit their minds will be like, oh, so much math. It's okay.
That's right.
It's manageable. So I want to thank you for joining us today.
My pleasure.
Vivian Health is very glad you were with us. And folks who are
listening,
if you have any comments or questions or want us to follow up with information, just visit us at hire.vivian.com. Thank you.